Good afternoon. So we are ready to start the afternoon session, and we have the privilege, in fact, to have huge representation from ISCVS. I mentioned already the real pioneer of endovascular treatment, Ted Dietrich, who is our teacher. In fact, we have a family member here, Dr. Jackson, who is a resident in surgery. So thank you for joining us. And you know already Dr. Reed, he is one of the previous president of International Society. And we have the board member, the present board member, Rebecca Riachi. It's I don't know how it's in Spanish, Riachi or Riachi. So coming from Mexico between two conferences, thank you for joining us. Great, thank you. So as the first topic, in fact, the accent of the session is pulmonary embolism, and in fact one of the topics that I'm starting. In fact, surprise. Yeah. So it's plug-based vascular closure devices. Can we have the presentation? Great. Dear colleagues and friends, thank you for your presence once again. I will speak about plug and not only plug-based, generally vascular closure devices. In fact, the vascular closure devices as a very important invention changed the endovascular landscape. Since the time of which in 1990 Juan Carlos Parodi implanted the first AAA endoprosthesis, many things changed, and all these procedures from minimally invasive surgical procedures in fact became really endovascular. The so-called minimalistic approach for many interventions is absolutely really possible only because of the existence of the vascular closure devices. There are not hundreds, thousands of publications showing how important are the vascular closure devices in the daily practice of endovascular intervention. And many systematic reviews and meta-analyses are showing how important are how they are facilitating the procedures and how they are really shortening the hospital stay. Is it possible always to implant a vascular closure device? Not really. There are many requirements, not only for the place where the vascular access, percutaneous vascular access, has to be performed, but also the anatomical features of the underlying artery. In fact, it's very important to make the puncture on the femoral level. I'm mentioning femoral level because on-label and off-label vascular closure devices also in our proper practice are utilized not only for femoral but also for carotid closure, brachial artery closure, subclavian or axillary artery closure. So there are many utilizations of vascular closure devices that can facilitate a procedure, but I will show you later it's possible to complicate a procedure. So it's important to take a look at the place of the vascular access, not to have a big calcium burden, not to have focal stenosis, because despite the vascular closure device is a low profile, these which are leaving something behind, these are the plug-based vascular closure devices, they can in fact completely close an artery, and in the presence of calcium it's not possible to implant a vascular closure device at all, so it's not possible. So, and because of that, in order to avoid complications like this one shown, these are false aneurysms, AV communications, full closure of the artery, or just the opposite, bleeding with a non-efficient closure. In order to avoid all these complications, we have to pay attention to the place of implantation. This is more or less our main target to use a vascular closure device. These are the EVER, TEVER, and TAVI procedures, but not only. Our experience, this is in fact not very recent statistics. We have implanted nowadays probably more than 1,000 suture-based closure devices and more than 2,000 plug-based closure devices like the MANTA and AngioSeal. So the AngioSeal, by historical point of view, is probably one of the first that was, and it's still not only was, it's still utilized in many instances. There are two versions, 6 French and 8 French, and it's very easy to be implanted. I will tell you a secret. The 8 French AngioSeal can be utilized up to 12 French access without any significant complication in case it's done thoroughly and very carefully with the control of the device itself. There are two components. One is intra-arterial component. It's almost like a sugar, lactate something. I will show in a minute the proper name. And above the artery, over the vessel, the anterior vessel wall, is the collagen sponge. So the anterior wall of the artery being between the outside sponge of collagen and the inside glycolate lactide, in fact, both components are resorbable. In 45 days, there is no more one molecule inside the artery or outside because they are resorbable. And it's in between, there is a suture. In fact, the inside anchor is the sugar, lactate glycolide, and outside is the collagen sponge. So this is more or less the procedure. After removing the procedural introducer, you put a wire, the short wire that is included into the set, or a long 0.35 inch wire. And after positioning this locator that is very well showing us that we are really inside, after being sure that we are inside, in fact, we open the first step, and after putting the anchor, and after feeling the resistance of the anchor, we put, after that, we push. In fact, the suture, we are pushing with the suture, with the knot, we are pushing the collagen over the vessel wall outside. This is more or less our experience with the AngioSeal for up to 2 years ago. We probably implanted 500 more after this time. And this is our TAVI, EVER, and TEVER experience during the years that is growing nowadays. And these are the percutaneous devices used in a relatively short period of time. Our TAVI experience is growing like everywhere in the world. And because of vascular closure devices, since 7 years, we didn't do no one TAVI with general surgery. Zero, pure zero, because we don't need the vascular surgical approach anymore because of the MANTA and PROGLIDE utilization. And this is allowing not to use general anesthesia because the procedure is short, it's painless, almost painless with conscious sedation. And in fact, there are many, I mentioned already, as you observe, I mentioned already the 3 more utilized vascular closure devices: suture-based PROGLIDE, AngioSeal for relatively small holes, and the MANTA for big holes. There is the version of 14 and 18 French. Okay, I mentioned already these obstacles. This is the MANTA. The guys from the producer, in fact Teleflex, when I mentioned that the MANTA is like a big AngioSeal, they were not very happy, but in fact it's quite true. The principle is the same, to have an inside anchor and outside button. And it's possible to apply again it's very important to mention. It's possible to be applied up to 24 French of vascular access, and of course keeping the rules: no calcification, good zone, at least 7 millimeter artery. So there are several very important rules to fulfill in order to have good closure after the implantation. There are several trials comparing MANTA and ProGlide. Probably one of the reasons is these two competitors, let's say, they are, in fact, because of the really explosion of TAVI and Ever. And nowadays, in order to be a little even more complex, I will share with you that there are many teams in which they are using in one and the same patient plug-based vascular closure device and suture-based closure device. So there are many teams, including here in the Balkan region, that are utilizing the ProGlide as the first step. That is a suture-based closure device, and they are completing the procedure with the addition of AngioSeal 8 French. So it's a routine practice. There are several publications promoting this this strategy, and in fact there are many hundreds of teams using one ProGlide and one AngioSeal. This is the MANTA implantation procedure, and as you can see, again, there is a we have to measure. This is one step more. We have to measure before putting the MANTA, even before making the vascular access over the first wire. We have to measure the depth of the anterior wall of the artery compared to the surface of the skin. So it's very important the anchor to be open close to the orifice, because in case the anchor is open too far from the orifice, sometimes in small arteries it's not possible anymore to pull the anchor and to position it on the place of the orifice. And this is almost for sure will close the artery. And in the beginning of our way, we had such several instances, and I will show one of these cases. But otherwise, in case it's done properly, it's absolutely excellent closure device. The MANTA itself has a special marker, metallic marker, that fluoroscopically, for a second procedure, will tell us which zone to avoid. It's possible to puncture there, but nevertheless it's better in case we do a second vascular access to go a little proximal or a little distal from the marker of the MANTA. And in fact, this is the procedure. Like mentioned already, we are removing the standard operational introducer, and after having the proper depth of the artery, on this level, we are opening with this small knob, this lever. We are in fact erasing the lever. We are continue pulling, and very similar to the AngioSeal, we feel the resistance, and after feeling the resistance, there is a special red marker. It means that the anchor is also just below the orifice. Continue pulling, we have a second click, and with the second click, the system is already closed. And this is in fact the final, and finally we cut the thread. And this is the final position and the final result. In case the hemostasis is not achieved immediately, that is happening sometimes. For example, too ambitious anticoagulation can be one of the reasons. We can add some protamine, so to reverse partially the heparin during the procedure. And we have to compress, of course, high arterial pressure is not a good idea to have hope that in high arterial pressure it will stop immediately. So controlling the hypertension, controlling the coagulation, and everything will be fine. This is a comparison I mentioned already, a comparison between plug-based and vascular-based closure devices. In fact, there are some advantages of the suture-based closure devices, and there are other advantages of the plug-based closure device. The suture-based technique is with a little higher incidence of good closure of the vessel. The plug-based manta, there are a little more complications, but in fact in both utilization, the necessity for switch to vascular surgery is not different. So it's more or less the same. I'm showing here, you see a plug-based manta that is in fact with obstruction, severe obstruction of the artery that was implanted the manta. But in our case, in my department, always before leaving the patient to go to the room, we are making an injection. We are making, because even if the patient is sleeping, we can realize if the closure is efficient or not, and if there is an obstruction. In such a situation, when we see an obstruction, in our case, we are having arm approach, and in 2 minutes by the arm, we can go all the way down to the manta zone, and we can cross the almost full occlusion. And there are two options. One option is just to make a ballooning, like in this case. What is doing the ballooning? In fact, in case the plug is not axial to the artery, but it's on the diagonal, in this situation, the balloon will oppose the anchor toward the vessel wall. So the anchor will be axillary to the, and this is the result after ballooning. In case this wouldn't result successful, we would have implanted a stent graft. Nowadays there are 6 French compatible stent grafts on the market that can be brought to the zone of problem in 1 minute. The big graft, of course, and the evascular iCast. And this is also, and of course, Doppler, our colleagues angiologists are extremely efficient to show if there is a problem or there is not a problem on the place of the closure device. So, as a take-home message, I would say that totally percutaneous approach for endovascular intervention is safe and feasible. And with the utilization of vascular closure devices and the experience and good expertise, following the rules and the IFU, it's possible to perform up to 24 French access interventions in all vascular territories of the body. And thank you very much for your attention. Comments or?
I have a quick comment for you, Ivo.
Yeah.
At the very beginning of your slides, you showed the importance of gaining access not above the inguinal ligament and not into profunda or so on. Ultrasound has been very helpful for the last few years. Are you routinely using ultrasound to gain access accurately now in many cases or all cases?
It's a great remark. In fact, I think in US, it's absolutely mandatory to use ultrasound during puncture, and there are many cath labs doing that. We have really excellent angiology team, Doppler, duplex ultrasound. In most of the cases, we don't use routinely in the cath lab, but routinely we have information by angiology, what is the situation with the artery. In case the artery is clear, free of calcium, the pulsation is good, the patient is not too obese. By the way, obesity. Obesity is a real enemy of good puncture, because in many cases, you know, the inguinal ligament is quite higher than the expected if we follow in fact, the inguinal zone by just outside anatomical, let's say, features. And because of that, in this situation, in case it's obese patient, and too much calcium by the duplex, we are using ultrasound in the cath lab. Or the other, let's say, trick is we are puncturing the radial artery in almost 90% of the cases of all endovascular procedures. And after putting from the radial pigtail just above the puncture, we are puncturing even without contrast, we are puncturing the head of the pigtail. So the pigtail positioned here or in the subclavian, we are doing that, we are going to do that tomorrow for the in situ fenestration. We are puncturing the axillary artery because axillary artery is outside of the chest. The subclavian arteries are not a good target for vascular access because it's inside the chest and there is no possibility for compression. And the axillary artery is outside of the chest, so it's possible to be compressed. And after positioning the pigtail from the radial to the axillary, we are puncturing the visualization by the fluoro, and we are puncturing the head of the pigtail. Yeah. Thank you.